And as this has evolved over this last couple of years, I'm realizing that this is one of the most important things I've ever talked about. And so let me share this concept with you. Historically, in completely edentulous patients, implants were put anatomically in front of the sinuses and in front of the mandibular canals. And if you're aware of what our history was when Granemark started bringing this into a clinical study, he had dental students basically working off their university grants in Sweden. And these dental students didn't have very much experience in anatomy at large, and they were afraid of the sinuses and afraid of the canals, so they put the implants in the front of the jaws, and they restored them with cantilevers based on available bone. And when they had a lot of bone, they put in 6 implants, and they didn't have a lot of bone, they put in 4. And then they would cantilever prostheses off the back, over the sinus areas or over the mandibular canal areas, and this treatment planning was basically put the implants in the front, cantilever the back. They would use the same treatment plan if the opposing arch had natural teeth. Now we know natural teeth have higher bite forces than an upper denture, but the treatment plan would be the same, even if the bite forces were high. They would use fewer implants if they were less bumpy, and the crown height is taller. And in fact, in the 1981 article that first we became aware of the Granemark approach here in the United States was in 81, and Lemon started talking about this in 81. This is the picture that was published. The crown height is measured in feet, the cantilever measured in yards. And for those of you that were there in the mid-80s, the common thing from the podium, 1984, they gave their consensus or their meeting in Toronto, in 85 in Chicago. So the mid-80s, the mantra that was said is that you could, quote, cantilever back to the spine, unquote. Now, we had a series of 3 universities do studies, and by the end of the 3rd year, we found that although they claimed they were doing it for 12 years, we couldn't get consistent data after 3 years. And so all of a sudden, everybody started talking about anterior-posterior distance and other force factors. But even today, this is a journal, an article published in a referee journal that I picked up just last year. The number of implants is reduced to 3. The crown height again, in feet, cantilever in yards, opposing natural dentition. The same theme in refereed articles are being shown and widely presented even today. So from 1985 to 2009, the concept is the same. Crown height doesn't matter, cantilever length, not significant, opposing arch, not significant, any treatment plan by existing bone volume. Then we have the historic concept of treatment planning by aesthetics. And that second wave of treatment planning that came through in the 90s was that now that we're using implants more in the partially edentulous patient, we should have implants that are the size of the teeth that we replace. This is a well-known lecture slide that I borrowed from France, and basically the regular size implants would have too much of an emergence angle. A larger diameter implant would have more of an emergence. And for people that aren't in our implant world, this makes a lot of sense because they're trying to make the implant look like a tooth. They forget an implant is not a tooth. Because when it comes down to picking an implant, they pick one that looks like a tooth. And the tooth is different than the implant. They'll have implant systems that copy a tooth root. And they're attractive because it's tapered, copies a tooth root. We have well-known speakers that say the regular size implant is too small. That you should have a 6mm implant to replace the central incisor rather than a 4mm implant. So the emergence will be better and the soft tissue grade will be better. And it makes sense to non-implant people. Make the implant the same size of the tooth. We've got guys now that take out the tooth, put it in a fresh material, pour some material in it, and stick a tooth of titanium back in it the same day, trying to make the implant look like a tooth. And then a wave came back to find out that if the implant is too close to the adjacent tooth, that if you lose bone on the implant, you lose bone on an adjacent tooth, then you end up that bone loss affecting the soft tissue greatly negatively. And that actually the natural teeth are often just a ½ millimeter apart. And so if you take an implant that's the same size as a tooth root, often it's a ½ millimeter from the adjacent tooth. And as a consequence, if you lose bone on the implant, you lose bone on the tooth, then you have an aesthetic nightmare. And so the backlash from that is now the implant should not be the same size as the tooth you replace. There should be other requirements based on what the size of the implant should be so that you're not compromising the bone and the bone of the adjacent tooth and the soft tissue drainage. Then the third wave, based on aesthetics, that I'm hearing the last 5-6 years, is that ovate pontics are more aesthetic than crowns on implants. Therefore, in the aesthetic zone, make as many ovate pontics as we can to improve the aesthetics. Well, is this treatment planning concept science or art form? It's not based on science. The cantilever wasn't based on science. I'll address that in a moment. Ovate pontics better than papilla for around implant crowns isn't based on science. It's based on art forms. And again, we keep following. People say, what do you think about this? And the art form of this. And even during the break, I said, you say all on 4 in the maxilla doesn't make sense, but where are the articles that show all the failures? I mean, it just, the system is designed to take you down the fastest, easiest path. And I remind you, if you would have taken the fastest, easiest path and wanted to be in dentistry, you wouldn't have been a dentist. You probably wouldn't have been an assistant. That's a hard job. You'd probably be a hygienist. And I'm not going to know, but if you're looking at the fastest, easiest thing, the program's half the length, there's the program's less, you get to pick your hours. You wouldn't have picked dentistry. Why are you always looking for the fastest, easiest method? Especially if we know that the impact force is greater, the mobility is less, and the occlusal awareness is less, and that the compromise of increased stresses are to the whole system, rather than living with the problems of the system, look at treatment planning something to reduce the early lobe failure, reduce the mechanical problems, and reduce the marginal bone loss. And to do that, one of the key factors once you design the prostheses, once you figure out what the prosthesis is going to be, all of a sudden key implant position becomes an incredibly important factor. And for me, key implant position means that position is so important to the prostheses that it warrants a bone graft. It warrants something to get an implant there. Because if I don't get an implant in that spot, I'm going to have significant biomechanical complications. Let me start with, I'm going to concentrate on treatment planning of partially edentulous patients here, in this shortened format. The partially edentulous patient. In the partially edentulous patient, I'm going to suggest that we do independent implant prostheses, and I'm certainly not the first one to suggest that. Although I'm going to tell you the reason why I suggest it is different than you might think. What I've been told is that the reason why you make independent implant prostheses from the surrounding teeth is because of biomechanics. That the teeth have mobility, that the implant does not. And as a consequence of the implant being rigid and the tooth is not rigid, Scalick back in the mid-80s said the physiologic movement of the tooth causes cantilevers with twice the applied load on the implant. That as a consequence of this extra load on the implant, because the tooth moves and the implant doesn't, that the implant has a potential risk of biomechanical complications. And as a consequence, that shot was heard around the world. Before the mid-80s, the American dentists routinely joint implants the teeth. After this concept, it became almost malpractice to do that, based on the difference in biomechanics. English said you'd overload the implant, disuse atrophy of bone around the tooth, improper loading of the teeth, failure of the cement bond, failure of the fixed partial denture framework, failure of the implant components. And indeed, those failures are possible. However, if you look at a number of studies, and the largest is LSU, sponsored by the NIH, you only had a 2% implant failure if you join an implant to a tooth. That you can handle the difference in the movement of a tooth and the movements of an implant very, very predictably. Because it's not that much of a difference. And you can handle that a number of ways prosthetically. And therefore, I'm not saying make them independent because of biomechanics, because in reality, if you know that there's a difference in movement, you can change occlusions, you can change methodologies, you can make the teeth more rigid by splitting them together. There's a number of things you can do together. that allow you to join implanted teeth, just like we used to do routinely prior to the mid-80s. The reason I say they should be independent are for biologic reasons. So this is weird. The biomechanic guy, finally when the industry says, do something because of biomechanics, I say, no, do it because of biology. Why do I do it because of biologic reasons? Because implants have no decay. And when a tooth is not joined to an adjacent tooth, it has less of a plaque trap, and it has less decay. A natural tooth that has a crown on it decays at less than 1 to 2% rate. An abutment of a 300 bridge decays at 22% rate. It goes from a 2% rate to a 22% rate because there's a splint next to it that's a plaque trap. And if you don't crown the tooth, it decays less and the implant doesn't decay. If I put the implant in, I have no endodontic risk on the implant. And if I don't prep the tooth, I have less endodontic risk on the tooth. And so the biologic problems of decay and lesions of endodontic origin are reduced if I don't join them to the implant. And therefore, the tooth has higher success rates. I have less perio risk. I have higher success, and complications are reduced. There is a biomechanical reason. The only reason you would join an implant to a natural tooth, the primary reason, is you don't have an implant next to the tooth. Therefore, you use the tooth to help support a pontic. But if I would say, look, I need an implant next to the tooth so I don't have a pontic or a cantilever, that means that that implant prosthesis would have more implants, more retention, less force to the bone because there's more surface area. So there is a secondary biomechanic reason of the additional implant as far as more retention, less uncemented restoration, less risk of bone loss, and other aspects of it. And so what I'm looking at now are partially edentulous patients making independent implant prostheses and looking within those potential implant positions, which are the most important implant positions, the ones that I would call the keys. And through the years, I've developed 4 principles that provide me the mechanism to determine the key implant position for a prosthesis. And again, key means this is important enough that I typically would do a bone graft to get it. No cantilever, no 3 adjacent pontics, the canine and first molar rule, and arch dynamics. Let's begin with no cantilever. Ever since Archimedes, before Christ, said, give me a lever long enough, fulcrum and place to stand, I can move the world. We've known about levers in physics and mechanics. If I take you back to your 4th or 5th grade science book or math book, there was a discussion of class 1 levers, and it was a teeter-totter that had a 25-pound child sitting 20 feet away from the fulcrum would balance a 50-pound child 10 feet from the fulcrum. 20 feet over 10 feet equals 2, so the mechanical advantage is 2. 2 times 25 is 50. The force on the fulcrum is the sum of the other 2, which is 75 pounds on the fulcrum. That's class 1 lever mechanics. And basically, when I wrote this article in the late 80s, I substituted feet with millimeters, and 25 pounds is a bite force for chewing. It takes 21 pounds to get through a piece of meat, 27 pounds to get through a raw carrot. The 25-pound bite force on a cantilever, 20 millimeters, if the implants are 10 millimeters apart, would generate a force of 50 pounds, twice as much to the front implant, and 3 times as much to the distal implant. And hence, the forces are increased. But if I look at some of the methods of treatment planning we do based on aesthetics, they suggest that pontics be used. And Garber wasn't the first one. This is a book that was published well before Garber started saying it. This is a book that goes back more than a decade with Farrell and Sullivan, in which they put an angle implant in the first premolar area, and they cantilever a canine off of the implant that's angled in the first premolar area, and they put a finger rest on the lateral. Of course, a finger rest is a trap. It's a psychologic trap because it's not a rest. This lateral incisor moves 97 microns with any lateral force, and so it's gone every time you need it. It's a plaque trap. It's a psychologic trap. It's not a rest. And the cantilever then comes off of this distal implant that's in the distal aspect of the premolar, so the length of the lever is here. And the concept is it's more aesthetic, because you don't have to have 2 implants in the ear. Instead, you've got an increased force on the system. I'm seeing this in more recent articles. This is one of a dozen articles that say the same thing, that if you're going to put implants in, don't put more implants in, at least leave a pontic between them so you can develop an ovate pontic. And I look at these articles that are being published over the last 5 years on ovate pontics, and one of the things I see routinely is that the height of the papilla is about 2 millimeters. Well, if all you're trying to get on an ovate pontic is a 2 millimeter papilla, this is one by Salama. If the height of the papilla you're trying to get is 2 millimeters, well, you should be able to get a 2 millimeter papilla next to 2 implant crowns. It's only 2 millimeters. And yet, when you put a cantilever on it, this is one that I saw in my office, the screw gets loose all the time. The screw is getting loose on this patient every month. Now, the implant's doing all right. There is some bone loss associated with it because the weak link is a loose screw. It accelerates screw loosening in the area. You can get papillae more than 2 millimeters between 2 implants, as long as they're not too close to each other. You can get papillae between 2 implants as long as you don't put them too close together. As long as they're not the same size as the tooth you replace, you can get papilla between them. And you're going to decrease screw loosening or uncemented restoration or the crestal bone loss or the other force factors that we've talked about with leverage. Hence, undersize the implants and put 2 in for the centrals, not ovate pontics. The limiting factor is, can I get 3 millimeters of tissue or more between them? If I can't get 3 millimeters or more tissue between them, I'm going to have trouble developing papillae. And so that's one of the limiting factors. The cantilever. This morning I talked about the survival rate of a traditional 3-unit, 4-unit bridge compared it to implant prostheses. I didn't mention cantilevers. Cantilevers, as I travel around the United States, I find that some areas of the country don't have any problems with cantilevers on natural teeth. Some areas of the country have significant problems with cantilevers on natural teeth. So part of it is, where did you go to school? But if I ask audience, is the success rate higher or lower if a cantilever is done? You should be aware that the cantilever prosthesis on natural teeth has a lower survival rate. It's lower than a traditional 3-unit bridge. And the mechanism of failure is biomechanics. It's an uncemented restoration. That basically with a cantilever, this goes down, this puts a tensile force up on the most distal abutment. And cement is weakest in tension. For example, zinc phosphate, 12,000 pounds per square inch in compression before it breaks. 500 in tension. And because the cement is so weak in tension compared to compression, it's the reason why when you try to take a crown off, you try to bang up on it. Nobody takes a hammer and bangs on top of the crown until the cement seal breaks and then lifts it off. That's stupid. You lift up on the crown and put that cement under shear and tension to break the cement seal. Well, that cement seal pops, and then a natural tooth that then decays, and it fails. And it has almost twice the failure rate of a traditional 3-unit bridge. Well, a cantilever on an implant prosthesis, my question to you would it be worse on an implant support to have a cantilever, or better, or the same? It'd be worse. See, because the teeth are mobile, when you have a tensile force put on the tooth, it comes up and the cement seal doesn't break as readily. In fact, a study by Lindy showed cantilever bridges work best on mobile teeth because the cement seals wouldn't break. And the more rigid the tooth, the more common the complication. Well, the implants are so rigid, the cement seal breaks easier than if it was a tooth. It's worse of a problem on implants than on teeth, and you don't like it on teeth. Now when a cement seal breaks, now you have one implant supporting 3 teeth. And the one implant supporting 3 teeth is now at much higher risk than it ever was before. It's worse to do cantilevers on implants than teeth. But what do we do with treatment planks now? Existing bone, we'll stick the implant in here and cantilever off here. And the cantilever increases stress highest to here, so there's bone loss to the second thread here. Doubles here, so there's bone loss to beyond the first thread here. And the bone loss, in part, is related to the cantilever. Well, the patient didn't want a sinus graft. Well, I addressed that this morning. If the patient doesn't want a sinus graft to put the implant in the right place, you should triple the fee. Triple the fee, because this is going to be a higher complication. And if you do only what the patient wants, then give them your car, give them your house. The patient wants everything. The treatment plan should not include a cantilever without knowing you're significantly increasing your risk, much more than if it was a cantilever on natural teeth. And the cantilever can increase screw loosening, increase bone loss, and overload to the prosthesis that doesn't fail. And you certainly don't want to put a cantilever in a molar area, which I'll address a little bit later. It increases the bone loss and increases the overload. And the force next to the cantilever has the highest force, and the implant is more prone to breakage or bone loss or uncemented restoration, and your complications go up. There's no reason to have a cantilever outside of the aesthetic zone. It increases your risk. Hence, one of the rules, if I'm missing 2 teeth, 3 teeth, I don't want a cantilever. Even if I'm trying to build a fill-up, I don't want a cantilever. My key implant abutments would be at each end of the prosthesis. Now, at this point, I'm not talking about the number of implants. I'm not saying if I'm going to stop at 2. I'm just saying a key implant position are the terminal ends of the restoration. If I'm missing 4 adjacent teeth, key implant abutments would be the terminal ends of the prosthesis. Usually that's not enough, but it's at least the terminal end. So here we're missing 4 adjacent teeth. I know that I want implants in the laterals. Those are key positions. There's inadequate bone in the laterals. Somebody had tried to grow some bone there with the membrane, was inadequate. I need to do a bone graft. I remove the membrane, I'm stretching the tissue. Once the tissue is released, I'll decorticate the sites and set up a regional acceleratory phenomenon. In this particular case, I'm taking some bone from the chin, harvesting the chin and putting it in the lateral and the central spots and having an Essex temporary. Coming back after 4 or so months, and the terminal abutments are the key abutments. Most often I would add at least 1 other. And so the terminal abutments are added. I added another one, and then we create the soft tissue drape, send it to the restoring dentist, then to finish up the case. And he sends me back these x-rays and this picture that is worthless. Let me look at 3 adjacent lines. 3 adjacent lines. As I've traveled around the United States, what I have seen is there seems to be no limit to the number of conics that are being shown in cases or in articles printed, as long as the abutments are strong. Now, there's agreement that if the abutment is mobile and tapered and has a problem, that you should limit the number of conics. But if the teeth are strong, there's almost no limitation to the number of conics I'm seeing written in journals. But if I look at, not only do these long spans mean there's fewer abutments for the stress to support the load, but there's also a condition in the metal that you learned also in that same 45-minute lecture you had as a freshman. You learned about metal flexibility, and that every bridge constructed, whether it's over water or over land or in the mouth, has material sciences that talk about flexure of metals. For example, in the book by Schillingberg, they've got a 1 pontic span. Nobody had ever measured the flexure of the metal in a 1 pontic span, so I got together with Phillips before he died, and we found that this metal flexes somewhere around 6 to 9 microns, not very much. A 2 pontic span. How much more does this metal flex compared to a 1 pontic span? It flexes 8 times more. Not only do these 2 abutments now take the load of 4 teeth, which may be questionable in itself, the metal between them flexes 8 times more. And I ask you, is that flexure worse on implants or on teeth? It's worse on implants. Because teeth have that mobility, that flexure, the cement seals don't break. It's less dangerous on teeth than it is on implants. The screw loosening, the vibration, the cement seal popping is a higher risk on implants than it is on teeth. Now with natural dentition, you go from a 3-unit bridge to a 4-unit bridge, the success rates go down. the success rates go down typically not because of the load, but because of the unsubmitted restoration and the higher risk of a mechanical complication. And it's worse on implants than it is on teeth. And so the 2-pontic bridge has a higher risk of failure than a 1-pontic bridge. Well, what about a 3-pontic prosthesis? How much more does the middle flex? It flexes 27 times more. And because the middle flexes 27 times more than a 1-pontic prosthesis, there are 3 textbooks in the literature that says this is contraindicated. In other words, not only do the survival rates go down on teeth, see, the survival rates go down again on natural teeth if you do this. This is an important enough a concept that in Schillingberg's book, Dykema and Phillips' book, Rosenthal's book, Laney's book, and Misch copied it. All those textbooks in prosthetics, and by the way, I'm not aware of any other books used in the United States in the specialty of prosthetics. These are the books used in the prosthetic specialty in every program in the United States. Every one of those books says it's contraindicated to have 3 ponics in the back of the mouth. I remember when I went through this road going through my prosthetic residency, I said, what do you mean by contraindicated? The professor says, let's put it in today's language, malpractice. I said, it's malpractice? I said, what about Anti's law? The surface area of the root should equal to be greater than the teeth replaced. Certainly if I'm willing to crown enough teeth, I can counter this through Anti's law. They say, okay, Misch, look up Anti's law. I go out in the library of Anti's law, published 1906 in a 4-page journal called the Michigan Bulletin with a little stick drawing and an idea that surface area of the root should equal to be greater than the teeth replaced. They should have called it Anti's hypothesis or idea, certainly not law. The law of engineering says this is too much flexure to keep the cement seals intact and the porcelain from not breaking and the complications associated with the metal flexure. Besides the fact that can 2 teeth take the load of 5 teeth, it's can 2 teeth take the load of that plus a flexure of 27 times between them. Now if this is malpractice to do on teeth, that indeed you should either do a partial denture or an implant prosthesis. If this is malpractice on teeth, it certainly has to be something against implants, because the flexure is more of a problem on implants than on teeth. The unsubmitted restoration, the decay as a consequence of porcelain fracture, is what should be found when 3 pontics are there. This is a case of John Horace in which, after the failure, he took some bone from the ramus, transplanted it to the body. After 4 months, came in and put implants in of adequate size in order to restore the case. So, what I'm suggesting then, if this is contraindicated for teeth, it's got to be contraindicated for implants. So if I have a treatment plan, these are mobile teeth, they're hopeless. We've taken them out, we put some implants in. I'm going to do an immediate restoration that ultimately then I restored a full arch mandible. I may have a cantilever because of the flexure of the mandible. That's a separate lecture, that's why I'm talking about partially edentulous here. I come to the opposing arch and I'm looking at the cuspid and 3 adjacent ponics. This thing is under a fixed prosthesis, the cuspid is endo, there's a 4 times higher risk this tooth will fail before it, and as a consequence, it will be appropriate treatment planning, rather than wait until the cuspid fails, to get rid of the 3 pontics, and indeed make an independent 3-unit prosthesis in the opposing arch, to get rid of the 3 pontics in the restoration, which means then that's important enough for me to intervene into an existing prosthesis that hasn't failed yet, because of the biomechanical perspective. Write down your questions. The group is way too big to be able to answer questions from the audience at this point. Okay? Write down the question, I'll answer them right after the break. Which means if I have 3 to 4 units, the terminal abutments are the keys. 5 to 14 units, the terminal abutments, and limit the ponics to 2. If I'm missing 4 teeth, the terminal abutments. If I'm missing 5 teeth, the terminal abutments and something else between them. If I'm missing 6 adjacent teeth, the keys would be the 2 terminals and limit the ponics to 2. No more than 2. If I had 7, the terminal abutments and something in the middle, those are the keys. And again, rarely would that be all I'm going to use, but those are the keys to limit the cantilever and the 3 adjacent pontics. Once I have decided I'm going to do a fixed restoration in a span of 7 teeth, I know I need implants in those 3 areas, even if I need to bone graft to get those sites. Let's go to another key. And again, this is prosthetically driven because I've got the prostheses in mind, and now I'm looking for the key implant positions in that intended prosthesis. The next rule is a canine and first molar. Within the biomechanics of an arch, once it is completed, there are certain positions in that arch that are more important than others. And if I look at the dental arch, the most important positions are the canines and the first molar. The canines and the first molar. Let's look at the cuspid position first. The canine is a particularly interesting tooth. Not only does it have more surface area than any other anterior tooth because it takes a load in 2 directions, whereas the sensors and laterals are primarily taking a load in 1 direction. And therefore the root changes surface area, design, and length. But it also has a unique physiology, anatomy, that the other teeth don't have. For example, out of the 12 cranial nerves we have in the body, the cranial nerve that has the most brain cells associated to a particular cranial nerve is not the vagus that goes to the whole body. It's not an optic that goes to the eyes. It's the dental nerve, the 5th cranial nerve. It has more neurons in the body than any other cranial nerve. And of all the structures the 5th cranial nerve innervates, the one structure that has the most brain cells associated with it is the cuspid. That's strange. 7 million years of development. This probably wasn't a coincidence. And in fact, if you take a cuspid and you go into an excursion on a canine, 2/3 of masseter muscle, 2/3 of temporalis muscle turn off, and the amount of the force on the cuspid is reduced if the posterior teeth don't hit. It's why you want to separate the posterior teeth in excursions. But if you would anesthetize the cuspid and go through the same excursion, more muscle mass fires. In other words, there's something in the PDL that goes to the brain that turns off the muscles of the masseter and temporalis. That's spooky. I mean, that is why teeth are so perfectly designed for biomechanics. It even turns off muscles in areas in which the risk of an overload situation exists with a lateral load. Well, if I look at the books in prosthetics, Schillingberg's book, Dykeman Phillips' book, Lady's book, Rosentiel's book, there's also a rule in prosthetics that says if the cuspid and 2 adjacent teeth are missing, it's contraindicated for a fixed prosthesis. In other words, if I'm missing the cuspid, the lateral, and the first premolar, that's the cuspid and 2 adjacent teeth. If I'm missing a cuspid, the first premolar, and the second premolar, that's the cuspid and 2 adjacent teeth. Even if I would split every other tooth in the arch, I shouldn't have 3 pontics in this area. Why? Well, it's got 3 pontics, 1 stripe. The magnitude of the load from the cuspid is much higher than the back. So you have a force of 25 to 35 pounds in the central. By the cuspid, it's up to 100 pounds. The magnitude of the force is increased. And because it's a canine position, you have a lateral force component in an excursion. And because of the length of the span, the amount of the force, and the direction of the force, this is contraindicated. Which means then, I need implants. Rather than crowning all these teeth and putting 3 pontics in the area, I need implants. It means I need an implanted cuspid in the 2nd premolar area. I want to implant a cuspid in the 2nd premolar area. Now, indeed, the 2nd premolar area often invades the sinus. I may need to do some kind of sinus manipulation to place an implant in the correct position. Here I have a patient that has deciduous teeth, cuspid, first molar, 2nd deciduous molar. These teeth are hopeless. They're going to be lost by lateral. She had an implant 'implant placed too early in her growth and development here, and it's acting submerged as a consequence. This is a cuspid first bi, second bi, permanent teeth. We're going to put an implant in the canine and the second premolar position. And so the 3 deciduous teeth are removed. The implants are placed 1.5 millimeters from the adjacent teeth. In this case, they were restored out of occlusion the same day as they were placed. It's part of the immediate restoration study that we did. So the abutments are prepped, the temporaries are placed out of occlusion, and the cuspid and the second premolar then, after the implants integrate, the temporaries are cut off, and then ultimately 2 3-inch bridges are fabricated around these terminal abutments. Cuspid, first bi, second bi, cuspid, first bi, second bi. If I'm missing the cuspid, the lateral, and the central, that's a cuspid and 2 adjacent teeth. No matter how many other teeth I would cap or crown, I shouldn't have 3 pontics, because the length of the span, the amount of the force, and the direction of the force. Hence, it's better to do implants. And the implant positions would be the central and the cuspid position. Those are the keys. The central and the cuspid position, even if I needed to do a bone graft in one of those areas. Now, I may need to add an additional implant, but the force factors are high, but right now I'm just talking about the keys. If I'm missing a lateral, a cuspid, and a first bi, there is some variance on this aspect of the treatment plan because there's a wide variance of the size of the lateral and size. So the average lateral size is 6.5 millimeters, but if there was anodontia associated with it, the average lateral for in an anodontia situation is 5.5, and it's often under 5 because the contralateral lateral is often small in those situations. And so if I look at getting rid of terminal abutments and then putting an implant in the cuspid position, I end up with 3. Well, often 3 is too many in that span. And as a consequence, if I am going to cantilever a lateral, because the lateral is less than 6 millimeters wide, I have no occlusion on it, it's only an aesthetic replacement. In an excursion, protrusive, lateral, it's an aesthetic cantilever of 5 millimeters. If I'm missing the first bi to central, the terminal abutments, and a cuspid, I add the cuspid to the terminal abutments. The cuspid is a particularly important position. So here we have a patient missing a central, the first premolar. Somebody had tried bone grafting in the area and it failed, so the case is referred to me. Can I put implants in that are small and angled and get them around this missing bone volume? Yes, I can, but I shouldn't. I should put an implant in the central and in the first premolar and the cuspid. So I'm reflecting the tissue, borrowing some bone from the chin, reconstruct that premaxilla, come back after a period of more than 4 months, re-enter the graft, put the implants in the central, the first bi, and the canine position. Those are my key implant positions. And this particular one, because of the deep bite, he's a male, I put one in the lateral also, and then ultimately restore those 4 teeth. If I'm missing the contralateral central to second bi, the terminal abutments and the cuspid, those are the keys. The terminal abutments and the cuspid. The terminal abutments, no cantilever, and the cuspid. If I'm missing the cuspid to the second bi, the terminal abutments, the cuspid, and no 3 adjacent pontics. Putting something between them would have an advantage in every arch form except perhaps a square arch form. Again, I'm talking an abbreviated format here. But the terminal abutments, the cuspid, and eliminate the span to no more than 2. Which brings me then to the first molar. The first molar. This one I'm seeing violated probably more than any of the others for anatomic limitations of bone height. The first molar. See, it's not a coincidence that in the anterior region, the cuspid has the largest surface area. And in the posterior area, where the bite force doubles, the teeth double surface area. That's not a coincidence. The body is putting 2 to 3 roots in the area where the force is double. And the area that the force is double, the body is putting 2 to 3 roots in depending on the arch, and what do? we put a cantilever because we don't do a sinus graft. And where the forces are 4 times higher than the front, we put a lever on it that doubles the force, and now they're 8 to 10 times higher off of the front implants. If the patient doesn't want a sinus graft, you should probably multiply the fee by 5, because the risk of complications go up 5 times. Don't treatment plan by the existing bone volume. If it justifies to put that many implants in a mandible, you need more implants than that in the maxilla, not a cantilever in the molar area. Which means that if I'm missing teeth in the posterior maxilla, I'm going to be doing a sinus graft on most every case. The implants are just, note that I'm picking the key implant positions before I look at the x-ray. If you look at the sequence that I have for treatment planning, I say, you pick the prostheses. Right then you know the key implant positions. I didn't say look at the bone. I said pick the prostheses by needs, desires of patient in anatomic needs. And then pick the key abutments without looking at the x-ray. When you develop a treatment plan initially, you should say to yourself, if I had all the bone in the world, all the time in the world, the patient had all the money in the world, I had all the training necessary to do the case properly, what would I do? And treatment planning is easy. It's when you look at the x-ray first and you start trying to compromise, putting it in an angle because I can get a Hounsfield value that's 0.2 points higher if I angle it at a 30-degree angle. And I'll get a Hounsfield factor a little bit higher, but I got to put a 30-degree angle on it, which magnifies the force by 50%. That's not based on science. That's based on availability. The second premolar to the second molar, the terminal abutments and the first molar. The fewest number of implants I'd put in the stat span would be 3, the terminal abutments and the first molar. And yet, I look at refereed journals all the time, and what do? We put an implant in the pterygoid area, which means it exits the bone here at a 30-degree angle, and we end up with 1 pontic, 2 pontic. Both molars are basically pontics here. The most common time I see this kind of treatment plan being done with pterygoid implants is in the oral surgery community. And I'm probably too obtuse in this presentation. I understand. I'm not going to make lots of friends. That's not why I get on the plane to come here. But I ask myself questions. In the oral surgery community, why are your first 6 patients, you're taking out 3rd molars, and your implant patient, you put in a 4th molar? Why don't you take these 3rd molars and orthodontically move them to the 4th molar position in case you need them one day? The reality is nobody likes 4th molars. Nobody likes 3rd molars. So why do we put implants in the 3rd or 4th molar position at an angle and put pontics in the molar area? Where God is putting in 6 to 9 roots, we put in a 30-degree pterygoid implant in the softest bone with an angle. I just ask myself questions. It's confusing to me. We should start orthodontically moving 3rd molars to the 4th molar site. Then it would be a consistent treatment plan approach. If I'm missing the second premolar, the first molar, and the second molar, it means I need to do a sinus graft. We do a Tatum lateral wall window. We put some bone in the area, whether you place the implant or not. Depends on a number of factors. After the bone is more mineralized, the key implant positions would be the second premolar, the second molar, and the first molar. Those are the key implant positions. And then ultimately, once the implants have integrated, we can then build a prosthesis on those 3 abutments. 3 abutments then end up with a 3-unit restoration. If I'm missing first by to second molar, the number of units, key implants are the same, the terminal abutments and the first molar. But here's an article. The first one I'm aware of that was published in JOMI is by a plastic surgeon out of Paris. Now, I understand in Europe, you don't always have to go to dental school. Once you're a physician, you can do dental implants. They've stopped doing that in Italy as of last year. You now have to go back to dental school. But if the guy's a plastic surgeon, putting an implant in the fifth molar area, having 3 pontics, and this is, again, almost a pontic in the area. This is almost 3 to 4 pontics. If this is 4 pontics, the metal's flexing 125 times more. Opposing natural dentition in an area of a 4th or 5th molar. In the softest bone we have in the mouth. Not a treatment plan based on a science of bone, a science of force, a science of occlusion, a prosthetic abutment. Again, if you had all the bone in the world, is that where you put the implants in? One angle implant in the first premolar and one angle implant in the fourth premolar if you had all the bone in the world? Of course not. You'd put them where the teeth go. That doesn't, to me, sound like such a strange foundation. Put the implants where the teeth go. It goes in the mandible too. We're missing 3 adjacent teeth, uncemented restoration, bone loss, furcation involvement, all the complications there that should happen. That should happen. The second molar is lost. If we're going to replace 4 teeth in the area, where are the key implant positions? The first premolar, the second premolar, and a molar. Now, in this particular patient, it was opted to put in the 4th, and then replace the 4 teeth with the 3 keys and 1 additional. But here I go again, another referee journal. The implant's placed in the 4th molar position, a ponic in the first molar, ponic in the second molar, and the 3rd molar is the abutment. That's here at a 15-degree angle, based on existing bone volume, not based on prosthetics. If I'm missing a central to a first molar, the keys are the central and the first molar, and the cuspid. Those are the keys. Rarely would that be enough, but that's no cantilever, no 3 adjacent ponics, and the canine and first molar molar. Again, typically if I was missing a canine in the first molar, the keys would be the canine in the first molar, but most often those 2 implants aren't enough to support those 4 teeth, especially with a lateral load on the canine. And so secondary implants are typically used whenever the forces are greater or the bone is softer. Again, this lecture is not talking about implant number yet, it's talking about the key implant positions. And the key implant position is not the existing bone volume and then multiple implants in pontics until we end up with the anterior abutment. That brings me to a concept of all-on-4. All-on-4 has been something that has been promoted worldwide. No matter where I go in the world, people know all-on-4. The company that sponsors this is twice as big as the second person in the industry. So of the 4 big companies we have in the world, this one is twice as big as number 2. And they support the concept of angle-loaded implants, 30-degree angled implants, that increase the force by 50%. And implants in the lateral areas. And in their artist rendition, they eliminate the first molar. They have the cuspid and 2 adjacent teeth missing, which is contraindicated in prosthetics. So that in itself goes against the rule of every textbook we have in prosthetics, the cuspid and 2 adjacent ponics. But at least the artist knows not the cantilever in the molar. Unfortunately, when you actually see cases, the implant's put in molar. So now we have 4 to 5 pontics, and the cuspid, and 3 adjacent teeth missing. And this is in referee journals. Again, if you did this on teeth, it's malpractice. You do it on implants, they publish it. I just ask myself questions. This is a manufacturer's handing out this slide series to surgeons to give their restoring dentals. It's missing the cuspid, lateral, central, lateral, cuspid. I called the manufacturer up, I said, do you know who the restoring dentist is on this case? And they said, yeah. So I give the guy a call, he's from California. I said, tell me, this case that this company's handing out, tell me the history of it. Has it been in the mouth more than 3 years? And he says, well, kinda. I said, what do you mean kinda? He says, well, the screws kept getting loose on one side repeatedly until the implants failed on the other side. So when it kept getting loose, I changed it to an overdenture and then lost one side. So those are the rest of the slides of that case that you were handing out to show what to do. That's what happened in 3 years. This is a case I had a periodontist show me when I was a board examiner for the ABOI. There's bone loss on this particular cuspid only. It's been in the mouth for less than a year. Missing first bicuspid, lateral, central, lateral, cuspid, first bite. There's 8 pontics across the front. It's contraindicated for 3 pontics, including a cuspid. I tell him, look, this is undersupported. It's under treatment plan. He says, Carl, you don't understand. This is an overdenture. Well, if you put a clip this direction, it rotates. A clip this direction rotates here. A clip this direction rotates here. A clip on here rotates here. In other words, it's rigid. It snaps in place, it doesn't move. And if it doesn't move, it means it's a fixed restoration that can be removed to be cleaned or taken out at night. But it's a fixed prosthesis when it's in the mouth, and therefore needs as many implants as it gets fixed, because it is fixed. Which brings me to the zygomatic implant. The zygomatic implant developed by a guy named Favreau out of Italy. He's a pterygoid, and he invited P.I. Granamark and myself to be keynote lecturers at his first meeting in Italy, at which he showed this implant. And the history that he gave from the podium was that he had a 12-year-old skull on his desk, because he's a pterygoid, and he found that the bone lateral to the sinus was 8 millimeters wide. So he developed an implant that would go lateral to the sinus. He didn't know that at 12-year-old, the maxillary sinus hasn't developed completely yet. It doesn't extend beyond the floor of the nose. And as a result, it is not laterally or inferior yet at the age of 12. And indeed, there may be 8 millimeters of bone in a 12-year-old child. When he actually started putting implants in the adult, he found that he was in air. So he made the implant 56 millimeters long so he could get to the zygomatic bone, which was the first bone that he found going in that direction. Now the drawings are showing sinuses that are 6-8 millimeters wide lateral. Of the thousands of sinus grafts we've done, we've never seen a lateral wall this thick. But this is a referee journal of which the implant comes in from the palate, because to engage the zygomatic arch, you've got to come in from the palate. If you don't, you hit the inferior orbit area. And now the eyeball's dropping down the cheek, because you're afraid of an airspace. And then I look at the referee journals, and they got zygomatic implants placed and pterygoid implants placed. How many times have you seen somebody send a patient to the orthodontist with their teeth and say, could you please move the teeth to the palate for me to restore them? Like, never? Now you have a cantilever to the buccal. You can't even get there with a probe to find it, let alone any hygiene. Forget about bacteria being a component of anything. I mean, this is made impossible for hygiene. You've got a cantilever to the buccal. You've got 1, 2, 3, 4, 5, 6, 7 pontics across the front. This is under-engineered because you're looking at existing bone volume. Now, the more recent articles on the zygomatic implant says do a sinus graft first. Elevate the sinus, put it in, and then do a graft. Well, if you're going to do a sinus graft, put the implant on the crest of the ridge. Don't stick it in the palate. And then they cantilever the molar. And where the forces are doubled, they put it on a lever, which makes the force now 5 times higher. And they cantilever out to the buccal, which makes the forces 300% higher. And their cuspid and 2 adjacent teeth are missing. It's under-engineered. Now, the newest concept is that the implant goes lateral to the sinus, so you don't have to invade it at all. And now this is a soft tissue implant that lays lateral to the sinus and has an angle load of 30 degrees. And the implants are in the lateral to the central area. That's the newest concept of the guy that developed all-on-4. And of course, with this concept here, your perio probe now has to be an endodontic spreader because a 12-millimeter length won't be long enough. And the cantilever in the molar area, and the cuspid and 2 adjacent teeth missing, and the case is under-engineered. Cantilever of the molar and the bite, and the cuspid not being replaced, and the 2 adjacent teeth not being, that's a span of 3 teeth from here to here, that's at least 3 teeth. The case is under-engineered. And I'm asking you to look at a case from a biomechanical rationale. Arch dynamics. I'll take an arch and I'll break it into 5 straight lines. The centrals and the laterals, the canine, the premolar and the molar are basically 5 straight lines for this open pentagon. And the rule of this open pentagon concept is if I have multiple adjacent teeth missing, I want at least 1 implant in each one of these 5 sections. For example, if I'm missing the first premolar to the first premolar, what's the fewest number of implants I should put in from a biomechanical rationale? 5. Premolars, canines, and something between. I should put in 5. Should have put in 5 to replace 4. You notice to replace 8. You notice a little difference in treatment planning. Instead of all on 4 with immediate load, I'm saying put in 5 when you're missing 8. That's a huge difference in a treatment planning perspective. First premolar to first premolar, the fewest number of implants I'd put in would be 5. Now, here's my problem. The sinus extends from the second premolar back. Because of Tatum, God bless you, within his vision, taking the lateral wall of the maxilla, rotating it up, putting a graft in this site, that's the most predictable place you can grow bone in the body. You can grow bone in height more predictably in a posterior maxilla, the floor of the sinus, than anywhere else in the body. In fact, you can use almost any material. Every time I look at a new material on the market and they try to prove it works because it's in a sinus graft, spit works in the sinus, as long as it's not yours. There is a wider range of materials that will work in a sinus than anything else I've seen anywhere. But here's my problem. You take those materials that you throw in an antrum that work all the time, and you put them in the premaxilla. They don't work every time. In fact, if you don't have a major component of an autograft in here, I haven't seen it predictable. And as a consequence, people will grow bone in the back, attempt to grow bone in the front, but the front doesn't grow bone as predictable as the back, and so they throw in pontics in the front. And there's no limitation to the pontics, and it goes into 5, 6, 7, 8 pontics across the front. If you don't have enough bone in the premaxilla to place implants, you need to get implants there. That means learn how to grow the bone or send it to somebody that can. Don't treat a plant to your limitation. Look at where the key implant should be, then look at the bone. If you don't have it, get the bone. If you don't have the bone, get it. If you don't have the bone, get it. Here we have a case missing first premolar. Car accident. Somebody had tried to grow a graft, grow some bone prior to it, sent me the case. I know the fewest number of implants I'll place is 5. And in this case, because it's a male and the crown height is tall, I'm probably going to put in 6. And so I put 6 implants into this area. The terminal abutments, the canines, the crown height is tall, so I added a 6th. And then we look at the height and the width of the teeth, and the height of the papillae, and the aesthetic contours of it. Because it's based on a foundation. You know, what I don't understand is that a patient understands that if you have pictures of different sizes and different weights, and you use the same little nail for all the pictures, the big pictures fall down. A patient knows that. If you're hanging pictures on the wall and one of them is in